So you want to learn how to assess abdominal pain? You found the perfect video. Hey Success Nation, my name is Dr. Erwin Kwun. I'm a GP based in the UK. In this video we will talk about the approach to abdominal pain. Abdominal pain is a common presentation that could represent a spectrum of conditions. This ranges from benign to life-threatening. Most abdominal pain is due to benign cause. Some will be serious and a few will be life-threatening. The purpose of this video is for educational use only and not for medical advice. Diagnosing abdominal pain may be difficult due to a number of different organs within the peritoneal cavity. These include the liver, pancreas, spleen, stomach, colon, appendix, reproductive organs, and large blood vessels. Moreover, abdominal pain may be due to referred pain from other organs. Mrs. Smith presents with pain in the abdomen. Doctor, I've got bad stomach pain. How would you assess Mrs. Smith? In primary care, access to investigations is limited, so accurate diagnosis of abdominal pain depends on a careful assessment. Good history taking and focused examination are crucial in diagnosis and management. We need to gather information about the presenting complaint. Can you think, what would you ask Mrs. Smith? A useful framework that can easily be remembered is SOCRATES. Site, onset, characteristic, radiation or referred pain, associated symptoms, timing, exacerbating and relieving factors, and last but not least, severity. A good starting point is to inquire about the site of the pain. You may ask Mrs. Smith, where is the pain located in relation to the belly button? It is helpful to imagine the abdomen divided in 9 different regions. Down the sides of the abdomen there are right and left hypochondriac regions, the right and left lumbar regions, and the right and left iliac regions. Down the middle of the abdomen are the epigastric region, the umbilical region, and the hypogastric region. Having basic knowledge of anatomy is useful. The location of the pain will enable you to identify the organs involved and narrow down your list of differential diagnoses. For example, epigastric pain may be due to myocardial infarction, lower lobe pneumonia, perforated stomach ulcer, or pancreatitis. If a patient presents with unexplained epigastric pain with associated symptoms such as weight loss or new onset of diabetes, make sure you consider pancreatic cancer as one of your differential. Pain in the right hypochondriac could be due to gallstone or liver disease. Pain in the right iliac fossa could be due to appendicitis. Pain in the left iliac fossa could be due to diverticulitis. Inquiring about the onset of the pain will give you more information about the nature of the pain. Ask whether the pain is of sudden onset, like flipping a switch. This could be due to rupture or torsion of an organ, for example ruptured aneurysm, ectopic pregnancy, torsion of testes or ovary. Abdominal pain building up over a few hours, also known as acute onset, could be due to appendicitis, pancreatitis, or small bowel obstruction. Progressive or insidious onset could be due to irritable bowel syndrome, celiac disease, or liver cirrhosis. Inquire about the characteristic of the pain. You may need to let the patient know what you mean by characteristic. So ask the patient whether the pain is colicky, a sharp pain, or a constricting pain. This will help them to describe the pain for you. If the pain is tearing in nature, this could be due to a dissecting aneurysm. A dull ache could be due to appendicitis or diverticulitis. Sharp and constant pain could be due to peritonitis. Constricting pain may be due to renal colic, or colicky pain may be due to obstruction or renal stone. Inquire about radiation or referred pain. Pain that radiates to the back may be due to aortic aneurysm, renal and pancreatic pain. Renal colic may radiate to the groin. Diaphragmatic irritation may cause referred pain to the shoulder tip. Unless you specifically ask about this question, the patient may not know. Gallbladder pain may radiate to the scapula. Inquire about associated symptoms. Ask about whether the patient has vomiting and the nature of the vomit. Is it undigested food or bilious product? Feculent vomiting suggests lower GI obstruction. Ask about hematemesis or melena. Inquire about the color of the stool and the urine. Is the stool pale? Is the urine dark, like dark color? This may suggest cholestasis. Inquire about new lumps in the abdominal regions or groin. Inquire about the patient's appetite. Is the patient eating and drinking? Ask when the patient had their last meal. Inquire about bowel motion. Ask whether the patient had any diarrhea or constipation. Are they still able to pass flatus? Inquire about any faint dizziness or palpitation. Inquire about fever or rigors. This suggests an infection, inquire about rash or itching, inquire about urinary symptoms such as dysuria, inquire about recent weight loss. Unexplained weight loss is a red flag that suggests malignancy. The timing of the pain is important to know about. Inquire whether the pain is intermittent. In other words, does the pain come and go? For example, colicky pain is associated with biliary colic or bowel obstruction. Constant pain may be a feature of peritonitis. Ask about exacerbating and relieving factors. What makes the pain worse? What makes the pain better? Pain that is worse on movement, coughing, or inspiration, and relieved by lying still with shallow breathing could be due to peritonitis. Pain relieved by leaning forward is a feature of acute pancreatitis. Pain that is worse on eating may be due to peptic ulcer or gallbladder disease. Abdominal pain relieved by eating suggests duodenal ulcer. Inquire about the severity of the pain. Ask the patient if possible to rate the pain on a scale of 1 to 10. The severity of the symptom may not be representative of the cause. Some patients have a high threshold for pain, others may have a lower threshold. Appendicitis or colon cancer may present with mild abdominal pain, while viral gastroenteritis may cause severe cramps. In a woman of childbearing age, don't forget to ask about pregnancy. Consider eliciting a gynecological and obstetric history. Ask about contraception, ask about last menstrual period, ask about a history of sexually transmitted infection. Make sure that you signpost your question before asking sensitive questions. Think about pelvic inflammatory disease that could be radiating to the abdomen, any history of previous ectopic pregnancy, history of vaginal bleeding. These are important features to ask. Be sure to elicit patients' ideas, concern, and expectation, as a patient health agenda is important in the management. If a patient is worried about cancer and you have not asked about the ideas, then you may not be able to address the concern and expectation. It is also important to ask about the impact of the pain on the patient's work and home life, because this will give you a better picture of the severity of the pain. Had the patient had to take time off work because of the abdominal pain, other things that the patient is not able to do? Be sure to ask about the psychosocial elements in context. Inquire about past medical history, past surgical history. Ask about the patient's medication. Are they taking any repeat medication? Have the patient been using NSAIDs or aspirin recently? This is a risk factor for gastritis. Ask about any allergies. Ask about smoking history, alcohol history. This would be very relevant in a history of abdominal pain, especially if you suspect malignancy or pancreatitis. Inquire about family history. Ask about any previous cancer. Ask about travel history. Has a patient been exposed to specific virus? You may want to offer examination of the abdomen, plus or minus digital rectal examination if necessary. Justify the reason for the examination to the patient. Let them know what you're looking for and what's the reason to examine them. If you're considering to perform a digital rectal examination, make sure that you take informed consent and offer a chaperone. Once you have taken a focused history and examined your patient, you may come up with a list of differential diagnoses. Think laterally, because abdominal pain may be due to medical causes such as pyelonephritis, diabetic ketoacidosis, inflammatory bowel disease. What investigations would you like to arrange for Mrs. Smith? The various investigations that could be arranged, it depends on what is your working diagnosis, what you're ruling out, and what you think is most likely. Use your clinical judgment to come up with a working diagnosis. Simple investigations include a urine dipstick to exclude urinary tract infection. You may want to do a urine pregnancy test. Blood test investigations include full blood count, UNEs, CRP, LFTs. If you suspect gallstone, you may want to arrange an ultrasound scan of the abdomen. If a patient presents with abdominal pain and associated unexplained weight loss, you may want to refer the patient under a 2-week weight referral to exclude malignancy. As you may have gathered, the management of abdominal pain will depend on the working diagnosis. Would you like to learn how to improve your consultation skills? Then I've got a video where I break down how to use consultation model and apply it to take a focus history and manage your consult. Click on the video to watch it. I'll see you in the next video. Take care everybody. Bye bye.